Hey guys. Hello.
Hi, Dr. Alsaati.
Hi, how are you? I'm doing well. I'm still having technical difficulties, but I'm joining from my phone for now while
Okay.
while I fix my desktop really quick. For some reason, I'm not able to log in, but I
I
just
see.
didn't want you guys to be waiting, so I joined from my phone really quick.
Sure, yeah. Meanwhile, I can introduce you.
Sure thing.
We all know Dr. Alsaati. She has done already. She has done already many sessions for us, and Dr. Alsaati, she is a practicing GI pathologist since 2017, and she's practicing in Covenant Pathology, San Francisco, California. And she did her residency and cytology fellowship and GI breast fellowship from Georgetown University in Washington, D.C. Originally from King Saud University, Saudi Arabia. So she had quite a medical journey right here. So we are waiting for her technical problems, some technical problems happening. So let's see.
Yeah, well, thank you for the introduction. Thank you very much. I am now entering into my Zoom account, the ID. Hold on one second. And launch meeting. I was okay. I should be here. All right. Okay. So I'm going to turn off my phone and use just the. All right.
You have to connect your, there you go.
Can everybody hear me now?
Yes.
Okay, great. Let me share my desktop really quick. And we will continue some of University of Michigan virtual slide box. And let's do that. Yes, start sharing. Okay. All right, now you guys can see it, right?
Yes.
Okay, perfect. As you can see, I was all over the place. Okay. So last thing, I think we did the pneumatosis intestinalis, which was, okay, for those who are following on the screen, we can, otherwise, if you have your own, if you're opening your own virtual box, it's on page 3 after we go to the GI slides. Then we went to, we did this, we did that, cribriform, inflammatory, acute infection, adenoma. It should be somewhere here.
There it is.
This is intestinalis. Okay.
Yeah.
Right. Okay. So now next it's the duodenum, and it's titled as duodenal hamartoma. Okay. So again, low power diagnosis is the first clue for any GI biopsy. Looking at that, they mentioned that it's a duodenum. So the location, apparently it's correct because the villus architecture in the top, and it's very pink. You usually get some bleeding into the lamina propria. And then there is like this big nodule within the submucosa. Let's go higher. We have the nice villi of the duodenum and the Paneth cells at the bottom. So we're good. You have a nice lymphoid aggregate. Again, keep it a habit to screen your surface before you move on to the elephant in the house. And then now you have a huge filling lesion in the middle of your duodenum. You have some dilated cystic ducts as well with mucinous it's like foveolar / mucinous epithelium. And you have, what's the striking lesion here? It's that you have also fat, okay? That the fat area here makes it a hamartomatous. Of course, this is a big Brunner gland, and you can call it hyperplastic venous Brunner gland hamartoma because of the presence of the fat in it. Always go deep in your slides. You see that area here? This is basically, it did not complete, like it sunk down, it wasn't fixed well, and it sunk down into the block when they started cutting. And it's not a very uncommon something we see in GI, because for some reason they think that GI doesn't need to be fixed enough. You know, if they did a biopsy at 8 in the morning, we can start processing at noon. Yes, we can. However, the formalin won't go deep in such big lesions. So here, this case for me needs reprocessing, or the histotech has to go deeper into the block. This is a nice duodenal hamartoma. Look how the fat is in between the Brunner glands. See that? Okay, so it's a very straightforward one. You don't have to worry about it. The very important part is sometimes you only get a piece of it. And sometimes we can't tell the relationship of the fat to the Brunner gland. Should we just call it Brunner gland hyperplasia versus a hamartoma? Honestly, there is not a lot of difference in management or prognosis or any precancerous lesion. So it's just based on terminology. For this one here, it qualifies as a hamartoma because the fat is infiltrating within it, inside it. All right. Let's close this and move on to this one, right? Yes. So no, we did this already. Okay. We are doing
Schwannoma.
Okay, location. Let's look. This is gastric mucosa, so we're looking at the stomach, and then a stomach. Okay, here's the thing. If the doctor came to me and gave me a biopsy and he called it stomach mass or stomach lesion, and I see normal overlying epithelium and I see a deep lymphoid aggregate, okay, I always go very, very deep. I want to see if the bite can get here, if he was able to do a bite as deep as here, or if it's carcinoid, I will also see a lot of it here. So deep lymphoid infiltrate is a very alarming sign for GI pathologists, okay? When you see those lymphoid lines at the very surface, you look for Helicobacter pylori. We call it the superficial belt of lymphocytes. You look for Helicobacter pylori upstairs, or plasma cells or whatever. But when you see it down here, you look for neoplasms or you look for soft tissue tumors. And obviously this is a great example of how there is lymphocytic rim around the Schwannian proliferation. Now, this could be a leiomyoma, cellular. This could be a schwannoma. This could be a gastrointestinal stromal tumor with smooth muscle differentiation. It could be anything. I am telling you, you have to do stains before we move any forward, okay? The location is good for both a schwannoma and a GIST, or a lyo, like everything. So yeah, all three markers have to be done. Apparently, definitely this was S100 positive. So, and you can see the herringbone and Verroque bodies here. Antony A, Antony B. I think Antony A is the cellular, Antony B is the more loose areas of the schwannoma. Okay, how do I sign it out? Of course, I only do biopsies. I don't do resections, but I would call it spindle cell lesion, most consistent with schwannoma. And that's it. It's as simple as that. They will go ahead and resect it if they want, or leave it. It's up to them. Okay.
So I have a question here. You said that if there are deep lymphoid infiltrates, then you should think of either malignancy. Now, in the portion of stomachs when we get for morbid obesity, there are quite many of them where there are deep lymphoid aggregates. They don't mean anything. I mean, we rule out H. pylori in them, yeah. But otherwise, I mean, I have seen that very often.
Yeah. Yeah, no, I agree with you. I think I just misspoke. I meant when the clinician is mentioning a nodule.
Right. Yeah,
Okay,
yeah.
so it has to be something that the doctor is seeing by his own eyes, and you don't see anything other than the deep lymphoid aggregates. Okay,
Right.
but of course, deep lymphocytes are almost all over the place in every biopsy you see. But it has to be more alarming to you when it is connected visually to a nodule. Okay.
Right. Got you. Yeah.
All right. Now next is granular cell tumor. All right. So okay, location is an esophagus. It's one of actually the common sites of that lesion. And I would personally also do other stains on this one. Okay. So this I will also not, I don't want to misadjust as well. So I'll do a dog one on this as well, just for the sake of completion. Of course, I know they're calling it granular cell. And let's look at the cells, each one at a time. Look at that. This is a beautiful cell with granularity inside it. And definitely it comes, the first thing that comes to your mind, especially that it's a good location for it. So your stain for granular cell tumor has to be your S100 stain. And look how nice. And of course, it's a benign tumor. It's not something that you should be worried about. Sometimes you see some scattered eos in between. Here's some. And there is like transecting vessels in between. But show it around and call it a case. Granular cell tumor. I had one in the breast, which was very interesting when I was around.
Breast is another site which happens. The granular cell
Yeah.
tumor.
Okay. All right. Next. All right, successurated adenoma with the superficial invasion. All right, today I have a case. Actually, today I just finished my consensus at 1 o'clock, and it was an SSA with dysplasia, very similar to this one. So the first thing we do is we go ahead and we confirm that this is a successurated adenoma. The reason is, so I know the one who placed this slide here called it an SSA with early invasion. However, I don't see features of sessile serrated adenoma in this slide, okay?
Yeah, I see tubular adenoma.
Yeah, it doesn't mean that it's not. It could be on a separate, but let me explain to you. When I get a polyp, and this is actually good for your practice as well, ladies, if you are looking at any GI biopsies, when you get a polyp, and the grocer said that it is one polyp and trisected, let's say piece 1, piece 2, and piece 3, okay? So you know for a fact that these all 3 belong to the same polyp and they're trisected. And let's say here you have sessile serrated changes. And on the same sessile serrated changes, you have another piece that has low grade, okay? So you're gonna call this sessile serrated adenoma with dysplasia, all right? Obviously here you have focal high grade as well. So that's what you will say. Now, if you have multiple pieces, multiple fragments, in my opinion, I cannot call it sessile serrated adenoma. I'm sorry, dysplasia arising from a sessile serrated adenoma unless it is one single piece. And I know that both elements are on the same piece, okay? If I have sort of a low grade or a high grade dysplasia that is completely separate from my sessile serrated adenoma fragment, then I will call it fragments of sessile serrated adenoma, fragments of tubular adenoma. And then the clinician has to make his mind. If he thinks he took 1 bite, 5 bites, 7 bites, it's not my call, okay? What if literally the clinician found 2 polyps and he called it only one, you know? So I'm not in a place where I can make this decision unless if it's not convincing. I know he is calling this early invasion.
Yeah, the invasion as well. I mean, are we sure that we are looking at the right slide?
Hold on. All right. Superficial invasive adenocarcinoma, incest-serrated adenoma, plus
The
margin.
positive margin.
Yeah, so
The same thing, yeah.
let's see if there's ink. Anyway, I think I got from my slide what I want to get, but
No, yeah, I think the slide must have
I think the case is much bigger than just these 3 fragments. I think
either it is bigger or else the slide might be like a wrong number. So they scanned a wrong number.
Anyway, well, to me, I will call this, you know, tubular adenoma with focal high-grade dysplasia.
High-grade.
Okay, this is what I will call this. All right. Next is enterohemorrhagic E. coli infection. Okay. Let's see. Isn't that so cool? Okay. So, all right. So we have surface epithelium that is completely denuded and fragmented over here. Let's go low power. See how you have nice crypts down there. And then once they come to the superficial, you feel like almost they are dying or atrophic. So this is your first low power kind of vision to what's going on. I don't have chronicity. Here I almost have like an ulceration / erosion. Look at that. Okay, I have like an eroded, ulcerated area. The lamina propria is almost like hyalinized. It's like inflamed, full of inflammation. It's filling the area. It's not to the extent that you will go ahead and do an amyloid stain. It's not like an ischemic pattern injury. It's more of erosion pattern injury. I think your surface is kind of burned out somehow. It's not, I wish I have a good ischemic pattern injury. In ischemia, you'll have that tethering on the top, and this area here will be so hyalinized and pink. This one, it's not hyalinized. Keep an eye on the difference. This is more of a granularity and inflammation of the epithelium. And obviously, a lot of chronic, a mixed inflammation and like an exudate look to it. This is all like a superficial exudate to it. I go up here again. I don't see the hyalinization that I see in ischemia or drug or radiation proctitis. I only see more of granularity and inflammation of the lamina propria. But my superficial glands, they are attenuated and they have active colitis. And this is a nice example. You see where you have pink cytoplasm to the surface here, to that surface. This is usually more of an external insult rather than an internal insult. Like if it is more of an ischemic pattern, you won't get that. Here you feel like the surface epithelium is fighting at the very from the surface, which is a nice example here from the active colitis as well. So for me, this one, I will call this active colitis, no chronicity. I will do a CMV. I'll say there's no CMV inclusions. And my highest differential diagnosis is infectious etiology. I don't see parasites. Also, this is another thing that I will call for parasites. I will say here, see here, it's almost like a dying area of, this is good for E. coli. But again, we don't call E. coli on biopsies. We just have to call it an infectious etiology. The doctor has to go ahead and do all the, identification of the infection. I would not call this, very important. If this is a 35-year-old female or male, whatever, I would not say in my differential or emerging IBD. Okay. The reason is I don't feel this IBD. It doesn't look like an IBD infection. Okay. I would say no histologic evidence of inflammatory bowel disease present in this sampling. I will actually be more persistent to say, I don't think this is IBD. Please don't even tell the patient that this might be IBD. Okay.
Yeah.
I have a lot of active inflammation outside. I have no chronicity whatsoever. And neither in IBD, you will have cryptitis. You will have crypt abscess. Look at here. You don't have not a single abscess, right? You only have surface erosion, eroded. You have active inflammation on the surface. You have some cryptitis, but it does not look like IBD. Okay, so keep that in mind. I feel like a lot of pathologists, just for completion purposes, they say this could also be emerging IBD, and it will not make any good to the patient if we are telling him that this might be IBD for somebody who is just going to be cured in 10 days.
I have a question there.
Yeah.
So, what about those dilated vessels and hemorrhage? So that is a part of EHEC because it's hemorrhagic enterocoli?
No. This all blood vessels here, they are iatrogenic. They happened during the biopsy taking because of how denuded and friable the epithelium is. The hemorrhagic enterocolitis, you will see hemosiderin more in the deep, okay? Like for instance, this area, see that? Okay, but everything that is bright red is happened during the biopsy, okay? Just always keep that in mind. We get a lot of doctors mentioning, oh, erythema, redness, and I see some blood vessels and some exacerbated RBCs in the lamina propria. And that's not what's causing it, okay? It might be because of how dilated these vessels are to the surface here, but it's never because of the RBCs in my lamina propria, because this all happened during the biopsy taking, okay?
Got you. Okay, thank you.
You're welcome. Next is duodenal vascular ectasia. I have one in the duodenum and one in the stomach. So again, this is something that we get commonly. It is not something that is significant at all, but it's nice to confirm to the clinician that, oh yes, you know what, we have also the ectatic blood vessels that you saw. One thing is it might be in people with cirrhosis or, yes, hold on, just, thank you very much. It might be in patients with some cirrhosis or portal hypertension, but it's not always the case. So you see those vessels here that's coming up. All right. It has to be a bigger, thicker walled vessels. This one here. It's also not our best example. I wish there are better than that.
I think we saw a nice example of that in the earlier session.
Earlier is correct. Yeah. But this is the, yeah, it's not our best. So let me see the stomach. Maybe there's stomach that the stomach has a better example. Okay, it's not a stomach. It's a duodenum. So somebody needs to go back and organize these slides for them. Here, you see how you have multiple thick-walled blood vessels, 1, 2, 3, 4, 5, 6 together. That's a good example of it. It's subtle. Oh my God, my colleague and I, it's actually a case of my colleague. We looked at it yesterday. It is a duodenal carcinoid. which is always a nightmare for me. It was almost like a villi like this, and like a little bit of carcinoid starting here. And then we went deeper, we did a synapto and chromo, and then boom, many more areas popped up in the background, which our eyes couldn't see earlier. It's so scary.
Wow.
I know, I know. All right, so let's move on. Glycogenic acanthosis. Okay. All right. I like this diagnosis if it makes sense, and I don't like it when I just try to make something out of it. Okay, so glycogenic acanthosis is a diagnosis of very insignificance, except that the clinician will tell you I have a nodule or a patch or a white patch in the esophagus. Okay, so and what it means is you have a nice, beautiful maturation, and then pretty much swelling of every superficial squamous epithelium on the top. Okay, and I think in the cervix we have something similar. I remember from my cytology fellowship. So so this is exactly what it is. Some people tell you that this is part of reflux. Some people tell you that this is very insignificant. There is nothing to do about it. Know that entity, blame the nodule on it when it's classic like this. Otherwise, not every swelling or edema in the esophagus, you will call it acanthosis, glycogenic acanthosis, okay? This here is very beautiful, okay? And I wish there is another example of sloughing esophagitis, because it will be a nice pattern to show you side by side. I know some of you were asking about it very earlier in our sessions. You see that area, you see that every cell has a nuclei in it. Now, sloughing esophagitis has a very similar pattern with no nuclei, okay? You will have patches of ghost cells, and it's very common, more common than you expect, okay? You will have, I might have like either 3 or 4 a month. So you have a lot of squamous epithelium with no nuclei, ghosts and ghosts of cells. And also in sloughing esophagitis, you can see a line that demarcates the area of the beginning of the sloughing and the normal esophagus. Okay, it's like a very nice linear demarcation. Keep that in mind. Always do a PAS, okay, or a GMS. So let's, before we move on, let me show you a brief overview of esophageal biopsies. Now we're looking at the esophagus that is not affected by glycogenic acanthosis. You can see the basal layer here. All right, that's the basal, and that's the basal cell area. And then you have maturation all to the way to the top. Now, very important on low power to see how much basal cells do you have. Is it 1/3, 2/3, or the whole thing? If it's just the 1/3, it should be a little bit less than the 1/3, then this is normal. If it is occupying the whole 1/3 and jumping all the way to the middle, then you have the basal cell hyperplasia. And then once you get the basal cell hyperplasia, you have to keep 2 differentials in your head, okay? 3 actually. Number 1, common is common, reflux. Number 2, eosinophilic esophagitis. Number 3 is infection. Now for here, I go higher. Of course, here we have to make sure that the orientation is proper. This is a good oriented part, okay? And this is also a good one here, very nicely oriented. So you have basal cells almost to the midway, okay? And then you go higher and you see there's spongiosis. And you have scattered lymphocytes, 1, 2, 3, 4, 5, 6, 7, whatever. And you don't have any eos, okay? And you don't have any neutrophils on the surface. This might be a neutrophil. Anyway, I'm gonna ignore it to make a point. This is a good reflux case, okay? So I will call this glycogenic acanthosis because the clinician is getting this nodule out. And then next line, adjacent esophageal squamous mucosa with reflux change, no increased eosinophils, okay? That's how I will diagnose this. I won't ignore my reflux, because if this is not significant, well, yes, this will be treated. Okay. So always remember your priorities. It's, okay. All right. Let's too much about this case. Any more questions before we move on? Okay, let's move on. Patchy, intense inflammation consistent with Crohn's disease. And we are in duodenum. Okay, patchy. Let's see. We're absolutely right. We're in the duodenum. Nice villi. For me, this is very non-significant area. Okay. Moving on, we look further. My duodenum appears to be very normal here. Let me look at this patch. Very normal duodenum. Look how beautiful villi. You have 1/3 with a lamina and the other third is protruding out. No blunting, no lymphocytes. This is the area where I look for lymphocytes, only the tip of the tip, okay? For increased lymphocytes to rule out increased intraepithelial lymphocytes or celiac disease. So all the pieces I moved around are intact. All right, I intentionally left the middle piece in the middle, this one, because now we're gonna look at it. Because look at low power. You can see nice villi, nice. I moved all the way here, nice villi, and then here I see some blunting. Okay, something is filling my lamina propria. Okay, before jumping here, you have to screen the rest of your sample. Okay, now I look here. Okay, all right. Can you guys hear me?
Yes.
Okay, good. So this is a duodenal biopsy with active duodenitis. Okay. When I see activity, I look for foveolar metaplasia. I don't have foveolar metaplasia. I can't blame my activity on peptic duodenitis. Okay, so now that checklist in my head is down. I cannot blame it on peptic duodenitis. Let's see. I have activity, no foveolar metaplasia, and I don't have ulceration. Okay, so these cases, I will do an H. pylori immunostain. Okay, not uncommon that I get H. pyloris on duodenums. Okay, so just a little bit background. H. pylori don't like intestinal metaplasia. Why? Because intestinal metaplasia, all right, is more alkaline and H. pylori like acidity. So H. pylori likes to live in the antrum, in the stomach, and then when the stomach and antrum, to defend themselves, they switch their mucosa into IM because they want to get rid of the insult. Okay, so that's when you have an antrum with IM, they will become migration phenomena and my H. pylori will go up to the body. Okay, until my body becomes extensively intestinal metaplasia. And then so it's going to go all the way down. What does the H. pylori do? The H. pylori is looking for somewhere to live. So it actually asks the duodenum to switch to peptic duodenitis. So it's the opposite. It's trying to make my duodenum a good environment for my H. pylori. So always when you see peptic duodenitis, of course, it's not always the case, but sometimes with extensive intestinal metaplasia, lots of changes happen. And peptic duodenitis is one of them. Not every peptic case, of course, 100%. Not every. I don't want you to get out, go out from this class knowing that peptic means HP. But some theories suggest that also peptic duodenitis is more to make the environment more happy for an H. pylori. So it happens for it to become more acidic. Anyway, long story short, I do H. pyloris on these cases as well. How do I sign them out? Of course. Now, this clinician or the person who submitted this case into this website, they know that the patient has Crohn's disease. But for me, Crohn's is in the differential, okay? I don't have granulomas to support that differential. But what will I say? I will say active duodenitis C comment. Under that, I will say no CMV, no H. pylori, no granulomas, and no dysplasia, and no features of celiac disease. Okay? And then in my comments say the histologic differential diagnosis include an infectious etiology versus an upper involvement of inflammatory bowel disease, open parentheses, Crohn's disease. And then I will have the clinician do some of them, if the patient is like 24 or something, I will call him on the phone. I'll tell him, I don't see a lower on this patient. Go ahead and do a lower. When you do the lower, please, I emphasize, and again, I tell you, if you are able to communicate well with the clinician, that will save the patient a lot. I emphasize, please do a terminal ileal biopsy. Lots of them, they will call it normal and they will move on. We need documentation that everything was normal in 2021. This way, when he comes in 2024, with a full-blown Crohn's disease, we know that we did the due diligence in 2001. For instance, I'm just giving you an example. Okay. If the patient has history of Crohn's disease, I will call this different. I will call this active duodenitis C comment. This may represent as an upper involvement of patient's known history of inflammatory bowel disease, Crohn's disease, period, no granulomata or dysplasia present. Other differential diagnoses include an infectious etiology, recommend clinical correlation. Okay. All right. Any more questions? Okay, this is a tough one, and you have to play with your report a lot to make it fit the right patient. Okay. Patchy active chronic inflammation with granuloma, that's Crohn's. Let's see. All right. Okay. Nice, right? Colon with a nice epithelioid, well-formed granuloma, non-caseating. All that description goes down, right? That's a very nice, well-formed. Let's see if we have active inflammation. Oh, by the way, the presence of granuloma is equal to chronic colitis, okay? So when you say epithelioid granuloma present, comma, no chronic colitis present, this doesn't work. Chronic colitis is also granuloma, the presence of granuloma. So what I would say is, I will say, let's say there is activity. Where's my activity? I don't even see activity. Let's see. Okay, I don't see activity. Let me go on low power. This is a lymphoid aggregate. Anyway, here maybe. No, anyway, if I have, oh, there's a small one here. If I have an active colitis, I'll say my, okay, here's what I'm gonna say. Chronic colitis, mild activity with rare well-formed epithelioid granuloma, which is only one. That's the only one in the whole biopsy, okay? And then, we don't know which part of the colon this is, but it doesn't matter, we have a granuloma. This is consistent with Crohn's disease, given the patient's known history, or this may represent Crohn's disease in the appropriate clinical setting, or the histologic differential diagnosis include inflammatory bowel disease, which is favored, versus an infection, of course, versus drug-induced injury, because some drugs will cause granulomas. So what we'll say is, and then I will also say AFP-GMS stain negative, or if this is lost on my deeper, I'll say AFP-GMS stain were attempted. However, the granuloma was lost on deeper levels. You have to mention that you did an infectious markers, and you move on. If you have multiple slides on the multiple, or multiple biopsies of the same patient, you might find granulomas somewhere else, which will support your diagnosis much further. Let's see, it seems like, I'm not sure if that's the same patient or not. Where is it? So only these. Let's see if this is, I don't think this is a granuloma. Okay, maybe he is trying to show us the erosion or active colitis in that same patient of Crohn's. See that activity, active colitis. Yeah, and this could be the case. Let me see. Let's screen for granuloma here. No. Okay. So this one, all I see is here the focal patchy active colitis. And here's the thing. The reason it's is a good one, you know how Crohn's disease have skip lesions and it's always patchy and it's you see how, so look at these. This one here is clean. This one here is clean. You can just focal patchiness here. So this also is good for that same definition, but definitely no granuloma on this one. Let's see the third image that he has. Oh, nice, huh? This is another granuloma here, and that's surface erosion. So again, those are all nice cases for you to go ahead and do AFP GMS. That's an early one. See that? Let me tell you how you pick it up on low power. So low power, 90% of your time has to be on low power. Please, please, please. There's so much information you pick on low power. What I do is I do low power. I hold a dot, a dotting pen, and I dot here, and I dot here, and this way, and then I go and I move throughout all my levels, all at 2x or 5 or 10x, and then I go on higher power. And you know, on higher power, I really don't want to spend hours here, which I know is not significant for me. So I will just go to my dotted area here and match it on the other level, go to my other dotted area here, match it on the other level. Okay, I made just from my low power, I made my high power much, much smoother. Okay, and I do high power, don't get me wrong. I do a lot of high power, but it's a targeted high power, not a random one. Okay, here's another probably one gonna be early. So this one, I would call it multiple epithelioid granulomas. I would definitely do an AFB here. I would for sure look for something here. It doesn't look at all TB to me, but just in case. I don't like lots of spaces in my granulomas, so I always screen them very well. Okay. And then patchy active chronic inflammation with granuloma, Crohn's, we did that. Ischemic ulcer and adenoma. Okay, let's see what we have here. Ischemic ulcer, almost like autolysis, right? When we look at cases with autopsy, I mean, this definitely is bringing back lots of autopsy memories, but look how there's a nice demarcation over here from the vessel that died and the vessel that's still viable. This is a beautiful, beautiful transition of ischemic colitis. This is this is full-blown colitis. You don't even have tethering or, you know, I mean, here you might have some still viable vessel and glands, but for the most part, it's all dead. It's nice to look for fibrin thrombi. Look at them.
Yeah, nice.
It's very nice to see them. Of course, they are in the arteries. Everything that is still pink are my vessels, my veins. Again, more of them here. Fibrin, clots. So this, we know the insult. So it's nice when you write down your diagnosis, say submucosal arterioles with fibrin thrombi present. This is all for resection specimens. I mean, I rarely have such beautiful deep biopsies of ischemia. Usually I get a bite with very little on it. Okay, and then look at this. This, I think, is more of a recanalization or something. And then obviously this is another incidental tubular adenoma from that colonic resection. Okay, so it's fun. It's not, obviously it's not a biopsy. It is a resection, as you can tell, and they found both the ischemia and an adenoma together, so they added it into our collection, which is nice. It had, but I meant to say the adenoma has nothing to do with the ischemic colitis. Microcystic cyst on the pancreas, the duodenum, preampullary duodenal wall cyst, groove pancreatitis. Let's see. Oh wait, wait, hold on. Am I not in my, okay, that duodenum, okay. So this is a resection, this is a Whipple, and this is the duodenum, and there should be like an ampullary duct, see that here? That's the duct. And then they're just telling us that this is a cyst of the pancreas. So this is pretty much, yes, I know in the section I have a duodenum, but this is a pancreatic cyst. Now we look on the, we don't have lining, or do we? I don't think I have lining here. Or maybe there is. So serious cyst. Simple pancreatic cyst. No high-grade dysplasia, no malignancy. But yes, it is a true cyst. It's not a simple cyst. Okay. We got a little of pancreas in our GI. Okay, next is stomach diffuse large B-cell lymphoma. I will try my best, ladies. Okay, let's see, what else do we have? We have this one, we have this one, CD3, and we have H&E. Let's start with H&E. Okay. For sure, looking at low power, this is a darker sample than I usually get. High power, I'm locating that to be my body. Okay. Screening for IM on my epithelium. I don't think so. I don't think this is just an artifact. And then now I go deep and see all the blue cells in between my glands. They're almost, my lymphocytes are the size of my glands, my oxyntic glands. And they're big, they're ugly, they're actively mitotic. I mean, look at this. This is in visualized mitosis there. So you pack it, you send it to heme consult and move on. No, just kidding. So definitely my two markers that I go to are CD3 and CD20, and my CD3 should be almost negative to call it B-cell lymphoma, and then my CD20 is too big, and I stop here. That's it. I really stop here. Akanksha, do you wanna put your expertise there in this case?
Well, so as you mentioned, the nuclei that are prominent nucleoli, vesicular chromatin, very ugly looking, all those are features of DLBCL. One thing that you don't see over here is you don't see nice lymphoepithelial lesions, so that's something to remember as well, because blastoid mantle and other things also remember.
Mm-hmm.
But after CD20, of course, for the DLBCL, you have to do the DLBCL panel. That would be BCL6, MUM1, and CD10, and that would be your Hans algorithm. So you're going to mention your Hans algorithm, CD10 positives, germinal center or non-germinal center. You'll do your Ki67, you'll see what it is. And then it could be, like a high-grade B-cell lymphoma with BCL6 plus minus BCL2 and MYC. So we'll also send it for fish as well. And that's about it. I mean, in some institutes, they also throw in a MYC stain in there as well, but this is like this is not worth it for sure. So those are your workup that you would do.
And MYC for double hit?
Yeah, MYC for double hit. And then make sure that you do a cyclin D1 as well for blastoid mantle in here as well. So just throw it in there too.
Okay. All right. Moving on. Submucosal lipoma of the duodenum.
Yeah, that's nice.
Self-explanatory. Yeah, so it's basically a duodenum with a large lipomatous proliferation, and always screen for your lipoblasts really quick. If you don't think about it, you won't look for it. So because it's actually very uncommon. So always keep in mind screening. I have a little advice for everybody who is junior, or for anyone who will be listening later on for their recordings. At the end of your slide, you're about to remove your slide and place it back on the tray. What could you have forgotten to look for? And then put it back on and just glance and move on. It will make you be able to sleep at night, I promise. Okay. So invasive squamous cell carcinoma of the anus. Okay. All right. So what do I have here? I have glandular lesion. I'm sorry, glandular component. I have squamous component. I have squamous component, squamous component with high-grade dysplasia. Very, very dysplastic over here. I mean, if not worse than that, invasive. Look at that. Basaloid pattern. It's all, I mean, this is the base. I mean, can you tell what's the base and what's the surface? We can't even tell in here. It's just all the same darkness all over. And then you have a little kind of squamous pearl here in the middle. And it's the squamous is between, I mean, the glans is between the squamous epithelium. And look at that, another island of squamous epithelium surrounded by muscle from here, from here, from here, from here, from here. That by itself is an invasive component. It's not tangential. Okay. The reason is I'm going through it very slowly and very carefully is because small bites, the orientation can be all over the place. And we have to draw it. We have to draw it in our heads before we commit whether or not this is invasive. This is flying out with fecal material on the side and some glandular component. For me, this area I would completely ignore because I don't have any submucosa or anything in it. My best, if I am to take a picture, I will take a picture of this focus and maybe see how there's lots of muscle here. That's a good one, but this doesn't have tumor. This is the best here. So this is invasive squamous cell carcinoma, okay? Unlike head and neck squamous cell carcinomas, the presence or absence of HPV positivity, which is likely to be positive in this case, doesn't affect a lot in terms of prognosis or management. Okay. So we don't routinely order HPV stains on these at all. Here, this is a nice focus of invasion. Look at that. Okay. But I would definitely do a P40 and that's it. That's all I would do on this case. Nothing else. Okay, I will call it right away. Maybe I'll call it even poorly differentiated carcinoma consistent with squamous cell carcinoma, or moderately to poorly differentiated squamous cell carcinoma. It depends on my day and how I feel. Okay. Moving on. Metastatic ring carcinoma, the nightmare, periumbilical region. So it's probably a soft tissue lesion. See it? So if we don't know that the patient has if we do not know if the patient has gastric adenocarcinoma, this case will require breast markers, lung markers, stomach markers, correct? I mean, I can't just jump to call this gastric primary right away. It has to be, of course, CK7, CK20, TTF1, GATA3. I mean, we have to look at everything before we move on. But yes, this is definitely malignant metastatic tumor into the soft tissue, wherever the origin of the soft tissue is. We're calling it periumbilical. Wow. Almost looks like normal. Like, okay, so these are normal. So these are normal, right? These are normal ducts. Right?
Yeah, I wonder where is this taken from?
They're
Did they
calling it
mention where the-
periumbilical. Is it breast? Anyway, but this is the tumor, not the first area. The normal. Yeah. Oh, here, see skin. So you have skin and you have metastatic malignancy. And so these are definitely normal components, the ones we fell on the first, like ducts, benign soft tissue ducts and stuff. Yeah, like, yeah, for sure these are normal. I can't call this at all cancer, okay? Okay, so they're adjacent to large vessels and so forth. Yeah, soft tissue components, normal soft tissue components, and skin with underlying metastatic carcinoma. Okay. Coalescent Crohn's disease with enterocutaneous fistula. Okay, again, that's going to be a resection because there's so much description in it. So this is the anoglandular junction, or no, not anal. It's going to be squamoglandular junction of some sort. Maybe their patient has a stoma or something. And this is a small bowel that is completely intact. Yeah, this is definitely a fistula takedown, for sure. And then this is our fistula tract, probably. This area here is where the fistula is. And then let's see Crohn's, features of Crohn's. It's too difficult. I don't think this is a classic. Maybe it's just maybe this is just telling us this is a fistula area in patient who has Crohn's. I don't think there's anything diagnostic from our end to describe what this is for. Okay, because for me this is a very normal small bowel. And for me, this is just the fistula region. Okay. I'll let it go. Not too much to spend on in terms of teaching. Iron pill gastritis. Okay. All right. So what do I have here? I have a stomach that is eroded. Okay, what does that mean? That means my surface is angry and it's becoming more villous look to it. It's more like corkscrewing almost here and here and here, like reactive changes, reactive gastropathy. So this is a first alarming sign for chemical gastropathy in my head. This is all in my head before I move on. Here again, it's more blunted and villy, like it's more kind of corkscrewy over here. We move on. And I see here this area, again, more chemical with some residues here. So again, more residues here and more residues here. See that? And then your second move here is to do an iron stain. Okay. once you do an iron stain, you will go ahead and highlight all the iron positive residue within the histiocytes and the lamina propria of this patient, or even the oxyntic cell, or even the epithelial component. And you will call this iron pill gastritis, okay? Because the definition of an iron pill gastritis is part of chemical gastritis or gastropathy, and you have to have the reactive gastropathy look to it, and then you will have the iron deposition. I actually have a case on my desk right now. Let's see, where's my iron stain? This one. I'm going to share with you my screen, and you have to excuse my primitive microscope camera, but oops. All right.
Yeah, let's test it. I mean, it
Yeah.
might work.
Yeah, we're going to test it. Where is, okay, let's see.
Can you maximize that screen?
Say that again.
Can you maximize that screen? You can also make it full screen.
Okay, hold on. All right. All right, this is the maximum I can go. Can you see?
Yep.
Okay, good. So this is a stomach in a patient who is just coming with abdominal pain, okay? I can't walk around a lot because there's a big lag, but this is the stomach epithelium right here at the bottom. And then what struck my eye is the pigment here. See that? You see that gray pigment there? Okay, good. The first thing I did is I did an iron stain. Okay. And I'll show you the area of interest. Okay. And now you are gonna go out of this session knowing a huge difference between two diseases. One of them is iron pill gastritis, and the other one is gastric siderosis. Okay? So if your iron stain is pretty much at the very top, then you have iron pill gastritis. You won't have that collection in the body here, okay? You won't have it. If your iron stain is pretty much at the very base of your pits, then you have gastric siderosis. And the significance of gastric siderosis, which I don't see very often, by the way, is it usually happens in patients who get a lot of blood transfusions or in patients with hemochromatosis. Okay, so in your description to the entity, you will say gastric type mucosa with gastric siderosis, and then in the comment you'll say iron stain highlights the increased uptake of oxyntic type mucosae or the oxyntic cells to the iron deposition. This is a feature called gastric siderosis, and the differential includes recurrent blood transfusions versus hemochromatosis. The most important one to rule out is, of course, hemochromatosis, because it will end up with many, many different problems, but blood transfusions is fine. Okay, so this is just on the side. I think it wasn't that bad, was it, Akanksha, the image?
Not at all, it was good. All you can do is a white balance, maybe try white balance.
Just press on it?
Yeah. And then press on the area that you want. It didn't work very well.
I don't know.
Auto balance.
I don't know if, okay, I'll play with it more. There you go. Maybe that's better.
There you go.
Okay.
Yeah. But it is working, and we can have slide session like that.
Okay, sounds good. Thank you, my dear. Okay, let's move on. And okay, we're here. So this is iron pill gastritis. If we did an iron stain on this one, our iron will be on the top. See that this one here is going to be iron positive. Maybe you'll get some deposits here, but none will be here. Look at the difference between the case I showed you and these. These are all nice color. There is no pigment within these oxyntic glands, okay? Moving on, let's turn this off, and serrated adenoma in the rectum. What does that mean? Traditional serrated adenoma? Yeah.
Yeah, it looks like that
Yes.
there.
Yes, because it's a little bit villous at the top here.
Mhm.
Would I call it? I'm not sure. I might just let it go as tubular adenoma. But I see some people might argue maybe he went deeper and the deepers were better, like it showed nice deep serration. It's not as pink to me to call it serrated adenoma. I might just call it a tubular adenoma. But I see the point. See how it's serrated here?
Mhm.
And by the way, traditional serrated adenoma is the follow-up is much closer than a tubular adenoma. So if you are in doubt, go with the higher grade. So you'll get the patient back closer. Okay. Now, what else? Sessile serrated adenoma, ileocecal valve. Now, this is an important one because the ileocecal valve is a tricky one because it's a transition between the like the colon and the ileum. But for here, I think this is, although it's ileocecal valve, but for here, it's pretty much within the colonic fragment of the valve. Because look at that. This should be enough for you to call it SSA, okay? That's it, don't even look further. Of course, you have to look for dysplasia, but you can go ahead and call it SSA just on based on that little fragment. This is a very nice case, by the way. The size of the tip should be either smaller or the same size of the base. And you can see here a nice example. Here's the tip, the smaller opening than the bottom, okay? What else? Let's see if we have a nice Italy root, maybe here starting to go. Anyway, okay, and just to let you know that the ileocecal valve, normally they will have this big fat pad. So this is not a lipoma, okay?
Yeah.
All right. All right, another one. What are KI67? Some of them, they do it to highlight the extent of the proliferative epithelium all the way to the top, and whether or not it's a focus of starting to be dysplastic. It is very subtle. We don't use it at all, but some pathologists are there was a big move of start to do it on every SSA, and nobody went anywhere with it. Okay, now well-differentiated neuroendocrine tumor or a carcinoid. Okay, nice, very beautiful. I mean, it's cords and nests of well-differentiated endocrine tumor. It is, let's see the background. I would love to see if there's atrophic gastritis. What do you think? No, this is beautiful accentic glands. These are just beautiful. This is the most healthy stomach body I've seen. It's so nice. And now you have carcinoids. So this is not the carcinoid that grows in patients with autoimmune atrophic gastritis. This is an actual gastric carcinoid, a true one, true gastric carcinoid. It wasn't like a little ECL cell hyperplasia that ended up with tumor. Okay, see that? So your usual stains, chromosynaptic KI67, send him for resection, and move on. All right. Hamartomatous polyp Cowden syndrome. We've done that before. We'll do it again. Again, anything with hamartoma, you should see fat and vessels. Let's see. I should have a better example than this. But let's see. Yeah, this is what he has. I don't see what he is. Oh, this whole thing, he doesn't have any other stains. I wonder if this is a perineurioma. See how the pink filling of the lamina propria looks pretty much like a perineurioma to me. Okay, soft tissue region, which can be seen in countenance. But nothing much. You have to do your stains. S100 EMA. EMA will be patchy and focal. S100 will be dead negative on these. Very non-specific, very non-significant as well. Glomus tumor of the stomach. We'll take a quick look. We're not going to spend a lot of time because we've already seen it. This is, make sure that we're looking at the stomach. Yes, we're looking at more of an antrum type mucosa, and then we look deep. That's, oh, sorry, I thought I was looking at a granular cell. Yes, glomus tumor, absolutely glomus tumor. So what are the stains that we do for glomus tumor?
SMA.
SMA. This is a nice one. I haven't seen one in a long time. It's the reticulin. See how it's showing the fibrotic area with the cords all the way in between all of them. It's a nice case. Very nice case. Okay. And hepatitis, portal hypertension, gastropath. Okay. All right. So stomach. Reactive gastropathy picture, right? Dilated vessels. Yes, thank you very much.
Also, whenever you get the chance to sign off the other form.
Okay,
it's on
okay.
the email.
Okay, thank you.
Yeah, no problem.
Yeah, so this is, sorry guys, reactive gastropathy, and I have a lot of dilated vessels here that reaches all the way to the surface. See how it's going all the way up to the top? It's a good case of portal hypertension. Always have to rule it out when you have such patients with big dilated vessels like that. I always try to look for history, look something, because this one to me doesn't look at all normal. And I'm not gonna just call it reactive gastropathy or chemical gastropathy. It's a much bigger picture than that. It's more of a portal hypertension, and you will have ectatic vessels all around the place. Okay, it has to be thick-walled vessels, not the very thin kind of lymphatics. This is all one vessel, one, it's coming all the way there. Okay, goes to the surface here. Of course, look for intestinal metaplasia and look for signet rings and shenanigan. 5 more minutes, Akanksha?
Sure, whenever you want to start.
Okay.
Yeah.
Candida esophagitis. All right, let's see if they have an H&E before we move on. There should be. Yes, okay. All right. Okay, low power. I have basal cell hyperplasia, right? I have papillomatosis. My papillae are pretty much longer than the usual. Yeah, I can call this reflux, no problem. I don't have lots of eos, and I have spongiosis. However, my surface is mature enough, but it's also friable. I would not do a GMS on this case. I would not do it, or a PIS, because I do see my fungi. I don't, you don't need it. I mean, it's okay, you can do it, but sometimes they're just too obvious. You don't have to, but it's sometimes very subtle, and sometimes I have cases where I don't have this. I have lots of active inflammation, for instance, here like this, and I don't have this. So let's look at the GMS and see how it looks. Okay, how beautiful, they're here. Just wanted to let you know that sometimes I make a diagnosis on like this one only. Okay, because I have a good background for it. Would you call it rare fungal organisms present? Oh my God, look at this. Let's go back to the H&E and see. I haven't seen that, right? We were so focused on the epithelium here on top, I almost missed this. But let's look at it on H&E. Oh, it wasn't deeper. See, it wasn't on the deeper. It only popped up on the deeper. With the difference. So the GMS is much bigger than the. Yeah. Wow. This patient had lots of fungus here as well. It's interesting, but yeah, you can still call it consistent with Candida, like rare fungal organisms present consistent with Candida species or something like that, or in the appropriate endoscopic settings, this is consistent with Candida esophagitis, something. Okay, if you have very little. Otherwise, your diagnostic line is Candida esophagitis. All right, fully developed collagenous sprue-like changes. All right, that's the duodenum. Okay, so a duodenum that looks like a stomach on low power. That's how I call it. I have a Brunner's gland, and I have probably very flattened villi here. In other words, you have maybe whatever. I mean, you don't have villi at all. I don't have any piece with villi. Let's see if this is a villus or no, it's just even a pseudovilli here. So this is very alarming. How do I handle these cases? Okay, first thing I do is I look at the age of the patient, look at the symptoms. Patient has diarrhea or something, or if the patient does have already a diagnosis of celiac disease. Okay, so this one I'll call it duodenal type mucosa because I have Brunner's gland with marked intraepithelial lymphocytes and complete villus blunting. Okay, and then in the comment and say this histology is seen in full-blown celiac sprue. Correlation with serology is recommended if not already established, because the patient might already have the diagnosis of celiac sprue, celiac disease. Okay, so I'll move on. That's all I do. However, I still look for my bugs. I still look for my activity, but nothing else. Questions? Okay, yeah. Don't forget, look for your bugs here for your Giardia, although it's usually not very inflamed like that. But look for it. You'll be surprised how much Giardia you have around you guys. Okay, last case, granular cell tumor. We looked at it, and this is, let's see, I didn't see that again. It's in our esophagus. Oh, very cute. Very cute, very subtle. You almost think that it's a muscle, so be careful. So this is another nice case of granular cell tumor. Okay. Alrighty.
Nice.
That's it for today. We finished page 3. We can do some tomorrow. Tomorrow I won't be in my office. I'll be at home, so I won't have the microscope with me. So, so we'll continue some from here. Or if you want anything else, if you want a particular thing, please text me and I'm happy to help. Okay.
Sure. Sounds like a plan. Thank you very much.
All right, you're welcome. You're absolutely welcome. Take care. Bye-bye.
Yeah. Bye-bye.